I didn't mean to say that. Okay, and now we got Clyde. I think Clyde Camo is here, which is great. Well, welcome, Clyde. And Gaspario is coming as well. So Dr. Mon from Goroka. So today I wanted to. It's very nice to see everybody here, and I've just. I got back from the hospital this morning at 3:30 in the morning, so I haven't had much sleep. So I'm sorry if I'm a little bit slow today, but we'll push on, I think. I was going to talk about paediatric oncology today and just try to give you an overview of the common cancers that occur in children in Papua New Guinea and talk a bit about how to diagnose them, how to recognise and diagnose them, and how to diagnose them in terms of their clinical picture, the laboratory investigations we would do, the imaging that we would do, including ultrasound imaging and CT scan imaging, and the treatments that we would need to give the common paediatric cancers, the cancers that are treatable and perhaps those that are not easily treatable. And I'll talk about the complications, and then I'll talk a bit about paediatric cancer emergencies, which often present to us. So that's the outline of the talk, and we'll get started. The cancers I'm going to talk about in a bit more detail are acute leukemia, which is the most common paediatric cancer, of course, and then lymphoma, a bit less common, a retinoblastoma, which is more common in Papua New Guinea than in many other countries. I'll also talk about chest tumours, because we often get presented with a child who has a mass in the mediastinum or a mass in the chest, and there are lots of different reasons for that, and sometimes we just treat them all as if they've got TB or an empyema, but some of them will have cancers, and it's good to recognise them early. I'll talk a bit about abdominal tumours, because in some abdominal tumours have a good prognosis if they're identified early and treated early. I'll just admit Simon Peter. And then, as I say, I'll talk a bit about cancer emergencies. So here we go. As I said, acute leukemia is the most common tumour, and we all need to be good at identifying children with acute leukemia, because often I think children with acute leukemia get missed. They get misdiagnosed as just having some other form of anemia or malaria or something like that, whereas we need to recognise the constellation of the three things, either the combination of having a problem with the red cells, which leads to, of course, pallor, a problem with the platelets, which leads to bleeding, and a problem with the white cells, which leads to increased risk of infection. And then the symptom that is actually quite common in many children, which is bone pain in acute leukemia. And so that combination of pallor and easy bruising and bleeding, of lethargy and anorexia because of anemia, and bone pain because of bony infiltration of the bones with leukemic cells, all relatively common. But pallor is the most important symptom. And when we see children who've got severe pallor, we've talked about this before, but we need to try to distinguish between pallor that is due to different conditions, whether it's due to iron deficiency or whether it's due to malaria, chronic malaria, or whether it's due to leukemia. And I'll just admit a couple of people as we go along. And the way you can identify that is simply by clinical examination and taking a really good history. So, you know, children who've got iron deficiency anemia don't have hepatosplenomegaly, but if they've got a large liver and a large spleen, then they're more at risk, of course, of having a malignancy like. Is it possible to mute your please? Thanks. In addition, many children with acute leukemia have the leukemia is not just in the blood, but it's also in the soft tissues, and there are many children with acute leukemia that have gum hypertrophy or skin infiltration. And sometimes the skin looks a little bit a bit green, and sometimes the gums are hypertrophied and bleeding. And when you're examining a child who's got pallor or anemia, then you need to look at their skin, see the colour, look at their gums and their mucous membranes to see if they've got gum hypertrophy. About 5 to 10% of children with acute leukemia will have central nervous system disease, so they may have neurological manifestations, but sometimes they just have white cells in their CSF when you do a lumbar puncture. So it's not always clinically identifiable. Some children present with pallor, and they have, when you do the lumbar puncture, you find there are white cells there, but they don't appear to have any neurological manifestations. And the same with testicular involvement in boys, of course. That occurs in a relatively small proportion of children, and it may not be manifest as any clinical problem, but some children, some boys have a testicular involvement with acute leukemia. I'll just admit, Geraldine, of the acute leukemias, it's useful to know which ones are more likely. And most of about 80% of acute leukemias are acute lymphoblastic leukemia or acute lymphoid leukemia. So they're from the lymphoid cell line, T cells or B cells mostly. And most of them are pre-B cells. Remember, leukemias are malignant transformations of primitive cells. So malignant transformation of a primitive lymphocyte is a pre-B ALL, and that's the most common type of acute leukemia. And about 10 or 15% of them are T cell ALL. That is, in your lymphocytes, we've got T cells and B cells, and most of the acute leukemias come from B cells or pre-B cells, the precursors. And some of them come from T cells, which arise in the thymus. And those children who've got T cell acute lymphoblastic leukemia, they look a bit different because they often have a mediastinal mass from their thymic tumor. So that's 80%. 80% of them are acute lymphoid leukemias. Is it possible for everybody to turn on their mute, please? It's a bit hard for, I think, I'll try to, it is. I'm not sure who it is, but whoever's got there, that's good, that's good. So 80% are acute lymphoid leukemias, 15% are acute myeloid leukemias. I'll talk about AML a little bit later. And then a very small proportion are chronic myeloid leukemias. In adults, of course, there's acute lymphoid, acute myeloid, chronic myeloid, chronic lymphoid, but children don't get chronic lymphoid leukemia, which is CLL, or chronic lymphoid leukemia, is really just an adult disease. It occurs mostly in older or elderly people rather than the acute lymphoid and acute myeloid leukemias that occur more in younger children, and a very small proportion have chronic myeloid leukemia in children. That's pretty uncommon, but just remember 80% are acute lymphoid leukemias and 15% are acute myeloid leukemias. Overall, acute lymphoid leukemia has a better prognosis than acute myeloid leukemia in general. Children with acute myeloid leukemia, often when they come to hospital, they're often quite a bit sicker than those children who've got acute lymphoid leukemia. When you look at this is acute lymphoid leukemia. This is a blood film of a child with acute lymphoid leukemia. And you can tell it's lymphoid leukemia because of the single lobe nucleus. These are lymphoblasts, and they're very large cells. These are the red cells, of course, and these are the lymphocytes, where they're lymphoblasts because they're very large cells, and they have a single nucleus. Right, I'll show you some acute myeloid leukemias, and you can tell the difference. They look quite different, but acute lymphoid leukemias have a very large nuclei making up most of the cell. The purple staining part of the cell is the nuclei, and there's only a little bit of cytoplasm you can see around the edge. In the old days, we used to say that the prognostic factors were the height of the white cell count. So if a child came in with a white cell count of 200, 300,000, then that was a bad prognostic feature. It still is. And very young children, so if you're under 1 year of age, or if you're an adolescent, you have generally a worse prognosis, whereas those children between 1 year and about 10 or 12 years, they generally have a better prognosis. And if your white cell count when you present is only 30,000 or 25,000 or 50,000 rather than 200,000, then you have a better prognosis. But these days we've got other prognostic factors that are looked at. And some of them are genetic factors, and it just tells you, I guess, that, you know, leukemias are a genetic abnormality typically, and they're not often a inherited genetic abnormality, but they're an abnormality that's occurred in the genome of the cells themselves. And so there's a couple of what we call translocations of chromosomes that make that are high risk factors for their risk factors or poor prognostic factors. One is a chromosomal translocation of 8 to 14. It doesn't matter what it is, but just to know that there are some, now these days, there are some genetic markers of poor prognosis. As well as that, we look at whether a child responds well to the first lot of chemotherapy. If they respond well to the first lot of chemotherapy, then generally they have a better prognosis than if they have a delayed response. If a child's got central nervous system disease, if they've got lots of leukemic blasts in their CSF, or they've got testicular disease, then they have a worse prognosis. And the reason for that is because the chemotherapy that we give intravenously doesn't actually get to the CSF or into the testicles, and so the testicular disease or CNS disease are what we call sanctuary sites for acute leukemia. That is, they're hidden largely from the chemotherapy, and it's actually very hard to. That's why we have to give intrathecal methotrexate to manage central nervous system disease. And for some people, some boys who've got testicular disease, they need special chemotherapy, or they need irradiation to manage their testicular disease. These days, the most important prognostic factor is when, after induction therapy, we look at this this concept called the minimal residual disease. That is, how much disease they've still got after 1 month of treatment. And if they've got really minimal disease, like it's almost gone by 1 month, or even the first couple of weeks, then we know that child's got a good prognosis. But if they've still got, say, 5% of their bone marrow is leukemic blasts, or they've got a small, 2 to 5% of minimal residual disease, then that's actually tells you that they've still got lots of resistant clones of the leukemic cells in their bone marrow, and it's likely that chemotherapy won't be effective over time. There'll be a recurrence of the resistant leukemic blasts, and they'll just come back. Children who've got T-cell ALL, to a T-cell, what we call T-cell phenotype, if they've got a mediastinal mass and it's not pre-B ALL, then they have a bit of a worse prognosis as well. But all, I mean, it doesn't mean we can't treat them all. It's just that we have to understand that children with different types of leukemia have different types of prognoses. That's all. The treatment is really, I'll just go through the sort of stages of treatment. You don't need to know in any real detail, I think, but just to know there are various stages of treatment. And the first stage is induction. So the child comes in and they're very unwell. They need, to begin with, they need preparation for induction, not induction, but preparation for induction with plenty of intravenous fluids, hyperhydration. We need to protect their kidneys, and then they get vincristine, daunorubicin or adriamycin, and prednisolone. They're the mainstays of treatment, and then asparaginase. So the 4 drugs that are used in the first month: vincristine, daunorubicin or adriamycin, prednisolone, just steroids, and asparaginase. And then if they've gone into remission, they go on to consolidation, and that's usually, most of that's given orally. So the induction phase is given intravenously typically, but the consolidation phase is often given orally, except the vincristine, which is intravenously, usually once a week. So vincristine, methotrexate, prednisolone, and 6-mercaptopurine. They're the oral drugs. And then central nervous system treatment. All children with leukemia need to have central nervous system prophylaxis or treatment, even if they don't have white cells in their CSF, because sometimes when even if you do a lumbar puncture and they don't have any white cells, there might be just some remnants of the leukemia in their CNS. And so we always give them intrathecal methotrexate, but more so if they've got CNS disease. And then they get what's called reinduction, so re-intensification using the same agents, vincristine, daunorubicin, prednisolone, and asparaginase. And then they go on to maintenance therapy, and that maintenance therapy is usually with prednisolone and 6-mercaptopurine, and that lasts for 2 years. So that keeps the leukemia, well, that makes sure that it doesn't come back and that there's no residual cells. These days, with that treatment program, 95% of children go into remission after induction, after the first month, and about 80% are successfully cured with chemotherapy. And that contrasts to 30 years ago, when probably 80% of children didn't survive. They almost all died, so the acute leukemia treatment's been very, very successful. That was acute lymphoblastic leukemia, or acute lymphoid leukemia. I want to talk a bit, just briefly, about acute myeloid leukemia. And remember I said that the leukemia is a malignant proliferation of the precursor cells of white cells. Okay, the white cells we know are lymphocytes and neutrophils, eosinophils and basophils as well, but mostly lymphocytes and neutrophils. And the precursor cells, the primitive cells, it's useful to know what they actually are. And so all white cells start with a stem cell, and the stem cell's in the bone marrow. And if they're going to differentiate into granulocytes, so become neutrophils, then they go through the various stages. So stem cells become what's called promyelocytes, and they become metamyelocytes, and they transform into myelocytes, and then they transform into band cells, and then they transform into neutrophils, and then they get released into the circulation. Sometimes you get bands in the circulation, and sometimes myelocytes. So when we look at a child who's got acute myeloid leukemia.
Larry, next week, okay, yes.
When we look at a child who's got acute myeloid leukemia, we can usually identify what the precursor cell is. And so acute myeloid leukemia, remember I said that of those acute lymphoid leukemias, you look at the cell, and a lymphoid leukemia is one big nucleus and a small amount of cytoplasm. But these nuclei are sort of bilobed, you see. They're bilobed or multilobed, and that's how you can tell they're myeloblasts, all right? These are myeloblasts, not lymphoblasts. So AML, a cancer of the myeloid white cell line. So this line of cells from stem cells, promyelocytes, metamyelocytes, myelocytes, bands, and neutrophils, and they're leukemias that have a malignant transformation of any one of these. About 15 to 20% of all childhood leukemias are AML, and then there's some others that there's one particular type of AML called acute promyelocytic leukemia, APML, promyelocytic. And the only thing to know about that is that these children almost always have a severe coagulopathy. They look like they've got severe disseminated intravascular coagulation, and a bit like they've got severe sepsis. And then there's another type called acute myelomonocytic leukemia, so again, one of the precursors. And they typically, they just have a slightly different phenotype. They typically have a lot of skin infiltration and gum hypertrophy. It's called chloroma, which is the soft tissue and skin infiltration with the acute leukemia. Central nervous system disease is more common with AML than it is with ALL. Survival rates are these days around about 1/2 to 3/4 of children will survive, but they need very intensive chemotherapy. It's quite hard to give, and often when they present, they're sicker with more sepsis and more bleeding and more I'll just let someone in, and more tissue disease. Okay, so we talked about acute lymphoid leukemia and acute myeloid leukemia. I want to talk a bit about lymphoma now, because they're the next type of cancers, the next most common type of cancers. And lymphomas can, just like leukemias, they can be either T cell or B cell. Remember, lymphomas they're all lymphoid tissue. It's not granulocytes, they're lymphoid tissue. And they can be either from the T cells or the B cells, B cell lymphocytes. And if they're T cell origin, they arise from the thymus, which is in the anterior mediastinum. And if they're a B cell origin, they're called Burkitt's lymphomas, B cell Burkitt's lymphomas. And about 70% of all lymphomas are Burkitt lymphomas, and they're more common in PNG. And I'll explain why they're more common in a moment. Now, the T cell ALL or T cell lymphomas, again, they're from the thymus origin. Most children with T cell ALL are between about 10 and 15 years. I saw a child this week who actually had T cell ALL, and she was only a year of age. So it certainly can occur in younger children, but mostly they're school-age children. And they often present with a mediastinal mass. Sometimes they present with wheezing or tracheal obstruction from their mediastinal mass. And sometimes they have a pleural effusion associated with their tumour. These children often have a large amount of mass disease because they've got a very big thymus, and they often have a large liver and spleen, and they've got large lymphadenopathy if they've got T cell ALL. And they're at high risk of having tumour lysis syndrome. I'll explain what that is in a minute, but when we are treating patients who've got T cell ALL, then they typically have, they're at high risk of having tumour lysis syndrome. This is a child who had a T cell ALL, and you can tell from this X-ray that the mediastinum is very wide, and it's the upper mediastinum. And if you looked at this, you would be able to say that this is definitely a mediastinal mass that's not just lymph nodes. If it was a lymph node mass, it would seem to be multi-lobed, whereas it looks quite uniform and smooth. And you can tell it's in the anterior mediastinum by doing a lateral X-ray. This is the heart here at the base, and above that is the mass. Right, and the middle mediastinum and the posterior mediastinum is free. It's just got the lung. But you can see in the upper anterior mediastinum, there's a very large mass, and it's almost certainly arising from the thymus in origin, not from para-aortic lymph nodes, because it just doesn't look like that. This could be a Hodgkin's disease, or it could be a T cell ALL. Just to look at the X-ray, it virtually couldn't be other things. Tumour lysis syndrome is one of those oncology emergencies that I mentioned. I wanted to talk a bit about a couple of oncology emergencies, one being tumour lysis syndrome and the other one being what we call hyperleukocytosis. And remember I said that children who present with acute leukemia, whether it's ALL or AML, if they've got a very high white cell count above 100,000, then they're at great risk of having both either hyperleukocytosis, which what that can lead to sometimes is a sludging of blood flow through the main vessels, particularly in the brain. And some children have strokes or cerebral hemorrhage because they've got obstruction of the microvasculature, obstruction of blood vessels because of their very large numbers of white cells in their blood. It makes the blood very viscous and slow flowing. And so strokes can occur if your white cell count is very high, like above 200 or 300,000, which we sometimes see. But they also are at great risk of getting tumour lysis syndrome. So when we first start treatment for these children, if we're giving them prednisolone or if we're giving them the induction chemotherapy, then they're likely to get a lot of cell lysis. That is, the cells die very quickly. And when cells die, they release all the chemicals that are inside the cells. So inside the cells, you've got lots of potassium and you've got lots of phosphate, And because you have DNA in the nucleus, the DNA breaks down too when they're hit with chemotherapy, and that releases a lot of uric acid. And so both all of the release of phosphate and potassium and uric acid lead to tumor lysis syndrome. And when you get a release of lots of potassium, that can cause obviously problems with the heart. It can cause rhythm problems, serious metabolic acidosis. And so that's very serious if a patient is getting hyperkalemic when they start treatment for cancer. The release of phosphate, which is heavily concentrated inside cells, all of our cells have lots of phosphate in it. When that gets released, when the cancer cells die, the phosphate combines with calcium, and that leads to the precipitation of calcium phosphate in lots of different organs, particularly blood vessels and in the kidneys. And it can also lead to hypocalcemia, because the calcium in the blood combines with phosphate, the massive amount of phosphate that's being released by these cells, and it can lead to dangerous hypocalcemia. So high potassium, low calcium is the features of tumor lysis syndrome. And then the uric acid and the calcium phosphate that gets deposited in the blood vessels and in the kidneys can lead to an injury to the kidneys and cause kidney failure. So high potassium, low calcium, high phosphate, and high uric acid are the features of tumor lysis syndrome, and that's what we have to manage usually in the first few days of starting treatment for leukemia. You can prevent tumor lysis syndrome somewhat by, first of all, hyperhydration of patients with, you can use an isotonic solution, normal saline, or perhaps better still, Hartmann's solution, or that's probably the best thing, with some added bicarbonate to that fluid. Excuse me, I'll just have to do something. So we can prevent tumor lysis syndrome by hyperhydration and with addition of bicarbonate, and that can help to alkalinize the urine and protect the kidneys. If you give more calcium to these patients, intravenous calcium, that just combines further with the phosphate and leads to more sort of calcium phosphate deposition in the blood vessels and in the kidneys. So that's not very good. And then we give allopurinol, which is a xanthine oxidase inhibitor, and that can prevent the breakdown of uric acid and prevents the sludging of uric acid in the kidneys. So there's a number of ways in which we need to treat patients in the first couple of days. This is a child who's got hypocalcemia. So he had severe tumor lysis syndrome with a hyperleukocytosis. His white cell count when he came in was 300,000. And when we started treating his cancer, predictably, his potassium went up a bit, his phosphate went up, his calcium went down, and this is what's called Frosteck's sign, which is he's got a degree of tetany, and then and only then was it appropriate to give him some calcium. Anyway, I won't talk about that, but this is a clinical feature that you sometimes see in children that have hypocalcemia. Sometimes they have seizures, sometimes they have what's called tetany. And you can correct it by giving calcium, but it's quite dangerous to do if the phosphate's high. These days, we've got a drug actually that allopurinol is available in PNG, but there is a new drug that's called rasburicase, and that virtually has eliminated tumor lysis syndrome, even in the most high-risk patients. But that's a hard drug to get. Oops. I was going to talk a bit about B-cell lymphoma. Remember I said that 70% of all lymphomas are B-cell in origin, 30% are T-cell in origin. the Burkitt's lymphoma are more common in everywhere. Actually, B-cell lymphomas are more common everywhere, but Burkitt lymphomas are particularly more common in PNG, and I'll explain why. Burkitt lymphoma is one of the fastest growing human cancers, and sometimes we see children who look like this, and we wonder why they presented so late. But in fact, a Burkitt lymphoma can grow very quickly, and so children often have, a relatively short history of fever and weight loss, night sweats, and painless lymph gland enlargement, or they may have a jaw swelling, or they might have gastrointestinal features of a Burkitt lymphoma, but it can grow very quickly, and it's often associated with Epstein-Barr virus infection and malaria, and I'll explain why that is in a minute. It's also associated with other viruses, particularly HHVs, human herpes virus 8, and is more common in people who've got HIV. Burkitt lymphoma presents usually with MASH disease, so often airway obstruction or gastrointestinal tract obstruction, and sometimes, because it can involve the spine, can present with spinal cord compression. I mean, the patients with a Burkitt's lymphoma may also have bone marrow involvement, so may have pancytopenia, so their white cell count is low, they're anemic, their platelet count is low, and they'll often, because it's a rapidly growing tumor, some of the tumor cells are growing very rapidly and some are dying. They'll have rapid turnover of cells, and their uric acid will often be very elevated, and their LDH will often be elevated too. There are sort of two types of Burkitt lymphoma, and one is the Burkitt lymphoma like this boy has, and this is the most common type, particularly in PNG, and it's sometimes called the African type. It involves the soft tissues of the jaw typically, and then there's another type, and that's more endemic, and it's associated with both Epstein-Barr virus and malaria. And then there's the other, what we call sporadic type, which is more typically involving the gastrointestinal tract and para-aortic lymph nodes. And so there are various types. Burkitt lymphomas are a bit more associated with genetic abnormality, and it's likely that again, it's not a genetic abnormality in all the cell lines of a child. They don't have a chromosomal problem or anything like that, but within their bone marrow, there's a genetic abnormality that is often an acquired genetic abnormality, and it's called the c-Myc proto-oncogene. And all that does is probably make children more susceptible to Burkitt lymphoma if they get Epstein-Barr virus infection in the setting of having had chronic malaria. And so that's the link, I suppose, that probably makes Burkitt lymphoma a bit more common in PNG and in Africa, the so-called endemic Burkitt lymphoma. It is, as I said, Burkitt lymphoma is more common in malaria holoendemic areas, particularly in coastal PNG, but also in the Highlands region and in many countries where malaria is not as well controlled. I think it's probably going down in incidence, Burkitt lymphoma, and the most recent, I mean, Dr. Anger did a study looking at the mix, I guess, of different types of cancers and compared that with a study that was done, I think, 20 years before, and there was more Burkitt lymphoma in 20 years before than what there was in the study that Dr. Anger did. And those Burkitt lymphomas seem to have gone down, and there was a bit more of the acute lymphoblastic leukemias, I think, were a bit more common. In most of the studies in PNG, Burkitt lymphoma makes up about 16% of childhood malignancies, and most children are early school age if they get a Burkitt, like the boy I showed you before. The males are more common than females, and again, the jaw or other facial structures are more commonly affected. About 20% affect the spine and cause spinal cord compression. So again, sometimes we mistake Burkitt lymphoma of the spine to be tuberculosis, but we need to look carefully. And as I say, there is a complex immunopathogenesis of Burkitt lymphomas, but if you think that in children who've got chronic they've got chronic malaria, or they've had recurrent malaria, and they get immune suppression from malaria, and they get and then they get Epstein-Barr virus, then it's more likely that their lymph nodes will develop a Burkitt lymphoma. And there does seem to be this this genetic abnormality that exists in some of the bone marrow or lymphoid cell lines that can predispose to Burkitt lymphoma after Epstein-Barr virus. Epstein-Barr virus, EBV, is like glandular fever. And so the combination of malaria and glandular fever and this c-Myc proto-oncogene. Proto-oncogene just means it's a gene that is causes cancer. Oncogenes are things that cause cancer, and it's a translocation, this c-Myc proto-oncogene. You don't need to know that, but just know that there is a sort of probably a genetic basis for some of these, but it doesn't mean it's inherited. So, you know, a person who has Burkitt lymphoma is not really more likely to give it to, it's not really more likely their siblings will also have a Burkitt lymphoma. Sometimes it happens, but it's not very likely, like other inherited diseases. This is a child I saw about a year ago with an abdominal Burkitt, and I just wanted to show the mass disease. This is a gastrointestinal Burkitt lymphoma. You can see his normal liver and his gallbladder and bowel, and this is the Burkitt lymphoma involving the bowel. I'll just show you something I think is rather nice. And this is what a Burkitt lymphoma looks like, which is the histopathological view of a Burkitt lymphoma. And pathologists often refer to this as a starry sky histology. And the reason for that is because the little Burkitt cells, the B cells, there's millions of these little B cells. And then within the B cells are these things called reactive histiocytes. So they're not the cancer cells, but they're reactive histiocytes. So histiocytes are like macrophages, aren't they? And people have likened this to this beautiful painting that Van Gogh did of Starry Night. This is his painting, and you can see that what the pathologists say is that it looks very much like Van Gogh's Starry Night. So the reactive histiocytes being the stars, and the sky being the neoplastic B cells. The treatment for Burkitt lymphoma has been worked out about 25 years ago in the Children's Hospital of Philadelphia. Excuse me. And the treatment has largely remained the same for the last 25 years. It's quite successful. Cyclophosphamide, vincristine, doxorubicin, and prednisolone. And if you started early, then it's quite successful treatment for a Burkitt's lymphoma. Many of the Burkitt's, as I said, children get tumor lysis syndrome because they've got mass disease, and we need to treat that to start with. And you need to have this standard therapy available for Burkitt lymphoma. I was going to talk a bit about retinoblastoma, but so we've talked about acute leukemia. We've talked about, I'll just admit someone else. We've talked about acute leukemia, both acute lymphoid leukemia and acute myeloid leukemia. We've talked about pre-B ALL being the common lymphoid leukemia, and of the common myeloid leukemias, all different types depending on the precursor cell that's affected. And we've talked about B-cell lymphomas, the Burkitt's, and we've talked about T-cell lymphomas, which are the ones that start from a thymic mass, and they're usually in older children. And we talked about how to treat them, and we talked a bit about the complications of treatment, which is often tumor lysis syndrome, and we've talked about hyperleukocytosis syndrome, where children present with very high white cell counts. The next cancer I wanted to mention was retinoblastomas, and retinoblastomas are, again, pretty common, more common in PNG than in many other countries, and it's not entirely clear why, except perhaps there's probably a genetic basis. Well, there is a genetic basis for many of the retinoblastomas. I don't think that the retinoblastomas are associated with like Burkitt's, that they're associated with malaria or other conditions. I think there's probably just a genetic inheritance for that for retinoblastomas. It's just a bit more common in Melanesian people. some retinoblastomas are not inherited, and they're just sporadic. They just occur just out of the blue. And then some are heritable retinoblastomas, and they're associated with what's called germline mutations. So they're mutations not in all the chromosomes of all the cells of the body, but just in the germ cells, in the sperm or the egg, and in the retinoblastoma gene. And about inherited retinoblastomas are more likely to be involve more than one eye, and this is very important because it has implications for the way those patients need to be treated. If they've got inherited multifocal retinoblastoma, then the only real treatment is a nucleation of both eyes, and of course the child will then be blind. If they don't have an inherited type of retinoblastoma, then usually the management of one eye will be sufficient. About a third are bilateral, so 2/3 aren't bilateral. The 2/3 only occur in one eye. What's important, I think, about retinoblastomas is trying to teach people to identify them early. And this child, the child I've shown you in the picture, obviously he presented very late when he's got severe proptosis and he's actually got bony involvement. You can see the swelling he's got on the side of his head. So this is a very, very late presenting retinoblastoma, and there's we must be able to identify children that present earlier, and that's why we need to teach health workers, and we all need to learn that there's a couple of early signs that we should really look for. We should think, could this be retinoblastoma? And the first one is a squint. And a child who develops a squint, who never had one from birth, and just develops a squint or a lazy eye, they need to be investigated for either a retinoblastoma or a brainstem tumor, but particularly a retinoblastoma. And the other feature is that they have when we usually look with an ophthalmoscope into the eye, you can see a red reflex of the eye. And you might not be so good at looking at the retina doing fundoscopy, but you can look for a red reflex. And if a child's got a retinoblastoma, they will often have a white reflex instead of a red reflex, and that's an important sign of a retinoblastoma. So look for a squint, or a strabismus, or nystagmus. When I say a red eye, I mean excuse me, I don't mean the red reflex. I mean the globe itself will be red and swollen, of course. So looking for early signs of retinoblastomas, I think, is very important, so that children, when they present, they don't have such advanced disease. Most children with retinoblastoma are less than 3 years of age. Almost all are less than 5 years of age. Sometimes it occurs in older children, but mostly not. But the main thing is just know the early signs of retinoblastoma, I think, is the best thing. There are a number of therapies that can be used for retinoblastoma, and I won't go through these in detail, but chemotherapy can be used, either systemic chemotherapy like I've described for leukemia and lymphoma, or sometimes local chemotherapy into the eye itself. Sometimes children are treated with cryotherapy or some other ablation therapy to the eye, or enucleation, removal of the eye. And then there's some new therapies where they put radioactive plaques in the eye, and that can lead to a reduction. But the main thing is that to try to get it early. And if the child is identified early, then without metastasis or spread to the bone or destruction of the orbit, then they can have a good outcome with systemic chemotherapy or with enucleation of the eye. Now, of course, the child will be blind in that eye, but still they'll be saved. But if you've got a child this advanced, then enucleation of the eye is not really of any value, because they've already got spread to the bones. The prognosis depends on the spread, whether it's involving the whole of the orbit and whether the bones are involved, etc. I was going to talk a bit about chest tumours now, and I've already spoken a bit about chest tumours in some of the description of lymphomas that I've talked about. But just to know that there are other types of chest tumours besides lymphomas. And to understand where a chest tumor is, it's good to describe whether it's in the mediastinum, it's a midline tumor, or whether it's in the anterior mediastinum or the posterior mediastinum. And simply by x-rays, you can find out whether a tumor is midline or unilateral, or whether it's anterior or middle or posterior mediastinum. And from that description, just where it is, you can usually get a good idea of what it is, right? And so remember I said that those tumors that are in the anterior mediastinum, midline tumors in the anterior mediastinum are much more likely to be from the thymus. They're more likely to be a T-cell lymphoma and sometimes a thymoma. That's less likely. If the tumor's in the posterior mediastinum, then they're more likely to be a neuroblastoma or a ganglioneuroma. A ganglioneuroma is usually a benign tumor. If they're unilateral, maybe involving a rib or maybe involving the chest wall or the muscles, then they're more likely to be a rhabdomyosarcoma, or they might be an osteosarcoma involving the bone. And so they're usually unilateral rather than midline tumors. And then there are other tumors that are typically unilateral, but they're big masses, and they have some characteristic features on the x-rays. So I think mostly with x-rays, you can get a pretty good idea of what type of tumor the chest tumors are. So for example, this child has a, you might look at this and you might say, well, this is a pleural effusion. And this child did have a pleural effusion. There's a whiteout of the left side of the chest, had a pleural effusion, but there actually is a big mass underneath this. And I guess that going back to principles, I want you to remember there's 4 reasons for a whiteout of one lung. There's only 4 reasons. One is fluid, so an effusion. And that effusion, that fluid can be either pus or just clear fluid, like in a TB effusion, or it could be blood, a hemothorax, or it could be lymph if there's obstruction or damage to the lymphatic vessels. So it can only be, there's lots of different types of fluid that can be there, but the main thing is fluid is one. Consolidation, so if a child's got pneumonia, that can give you a whiteout. But if you've got consolidation, you'll see air bronchograms. If you've got a fluid, you usually see a meniscus sign, not always, but usually see a meniscus sign. Consolidation, you'll see air bronchograms. Collapse, you'll see, if there's a lung collapse, there'll be a whiteout of the lung sometimes. And then the mediastinum will be shifted over to the side of the lesion. And then the last thing is a mass. And so fluid, consolidation, collapse, or a mass. You just need to remember there's only four reasons for a child to have a whiteout of the chest. And fluid could be TB, or it could be pneumonia, or it could be a hemothorax from bleeding. Consolidation could be pneumonia or TB. Collapse could be bronchial obstruction or endobronchial TB, or just collapse from, sometimes you see lung collapse in asthma, for example, or a mass can be any of these types of chest tumors that I've mentioned. This, for example, is a child who had a chest tumor, and sometimes fluid and a mass can occur at the same time. So this was a boy who had a teratoma of the chest, and he had fluid. This is a sagittal CT scan, and you can see the fluid at the base, and then there's the mass sitting above it, and then the black is the normal lung, and you can see the very large tumor this boy's got. This was a child I just saw in the last couple of days, actually, who had, I thought to begin with, I thought probably he had you look at this x-ray and you think, hopefully it's just a parapneumonic effusion. Maybe he's just got pneumococcal pneumonia and he's got an effusion, but he turned out to have unfortunately, a disseminated neuroblastoma with a malignant effusion. And so that's not a good thing, but it looks just like a parapneumonic effusion, doesn't it? You would say this child might have staph pneumonia or pneumococcal pneumonia, but when we did a scan, you can see the tumor there. And he does, of course, have an effusion, but it's a malignant effusion, and this is the white part here. This is his heart. This is his heart, and on the left side there's a big mass, which is actually the disseminated neuroblastoma, and then there's the fluid. So as I say, it can just look like staph pneumonia, but that's why we need to keep an open mind. When we drained the fluid, the mass was still there, and there's the CT scan. You could sort of see it a bit on ultrasound too, but the CT scan was a better picture. I show this X-ray. This is another child. I show this X-ray because this child also has an almost white out of the left chest. But what you can see in the X-ray is some other sort of bright white areas, can't you? Bright white areas here. And you look, you might think, oh, there's been some contrast or something given. It's not contrast. This is just calcification of a teratoma. Now, remember, a teratoma, we said, it's a unilateral chest mass. And a teratoma is a germ cell tumor. And those germ cells, those primitive cells, can give rise to lots of different types of tumor. So sometimes you see calcified bone or other differentiated cells or tissue within a teratoma. A teratoma has usually got a good prognosis. This tumor was able to be just cut out by the surgeons, and the child had a good prognosis. Needs some chemotherapy afterwards. But so when you're looking at these, look for variegated, what we call variegated tissue within the tumor, because that might be a teratoma. If there's if the tissue is heterogeneous. It's different if it's like this, if it's completely whited out. It could be a teratoma, but it's more likely to be something else, like a really solid tumor. This is a very solid tumor, whereas a teratoma can be sometimes a bit cystic, a bit bony, or it can be some other tissue in muscle or other tissue in it. Yeah. Okay. A teratoma is a chest tumor. Sometimes it also can involve other things. It's not midline. It involves the anterior mediastinum, and particularly it's got a heterogeneous appearance, and it's a germ cell tumor. So it might have some bone or connective tissue. Yeah. Okay. Teratomas can exist also outside the chest, and it can involve the testes or the ovaries. And you can get a good idea that it's tumors a teratoma by looking at these things called tumor markers. So if you can measure beta HCG or alpha fetoprotein, usually one of those can be measured, and they're usually very high. There's another teratoma called a sacrococcygeal teratoma, and that's actually a congenital tumor, usually congenital sacrococcygeal teratoma. And that's often, it's quite benign, but it can sometimes cause obviously obstructed labor. These tumors are usually good to treat. So this patient was able to have the tumor completely resected, and then some surgery to refashion the perineum. But this baby was fine after removal of the large tumor. It was able to be cut out very easily. I wanted to mention abdominal tumors. And I've mentioned these a little bit in some of the things I've said. So I've mentioned Burkitt's, and I've mentioned neuroblastomas briefly, and teratomas. But the tumor with the best prognosis of all the solid cancers in children are Wilms tumors. And so we really need to be trying to make the diagnosis of a Wilms tumor as early as possible. And the reason for that is because even with relatively simple chemotherapy, children with even stage 2 or stage 3 Wilms tumor have a very good prognosis. They have 85 to 90% complete cure with fairly easy chemotherapy and surgery. So surgery plus usually about 3 to 4 months of chemotherapy, they can have a very good prognosis. So it's good to identify Wilms tumors. They cause, as I'm sure you know, a painless abdominal mass. They're arising from the kidney. So they're what's called a nephroblastoma, because they arise from the kidney. Different to a neuroblastoma. The neuroblastoma arises from the adrenal glands or the sympathetic nervous system, but a nephroblastoma, nephro meaning kidney, it arises from the kidney. Some of them present not just with a painless mass, but they can cause a bit of pain if they start to bleed or they rupture. That's quite bad, but they present with pain, and sometimes they present with hematuria because they've eroded into the kidney, and they can present with hematuria and high blood pressure. They're sometimes associated in some children with other congenital abnormalities because there's a genetic predisposition to some forms of Wilms tumor, although most Wilms tumors aren't genetically predisposed to. But sometimes children have other abnormalities like hypospadias or hemihypertrophy. That means they've got one side of their body is a bit bigger than the other, or lack of an iris in their eye. So there's just some strange connections in genetic abnormalities. But most children with Wilms tumor, they don't have any of those things. They're mostly unilateral, and I guess like a retinoblastoma, a small proportion of them are bilateral, and they're more likely to be genetically inherited. They metastasize to the liver and the lung, and sometimes up the renal vein and into the inferior vena cava. But again, even if they metastasize to the renal vein or even to the liver, you can still treat these Wilms tumors pretty well, usually with surgery or chemotherapy. That's the Wilms tumor there. Look, this is an ultrasound of the child's kidney. It's a bit dilated, but you can see that within the kidney there's a mass. You can certainly feel it as well. The question always is whether if you see a mass inside the kidney, is it cystic or solid? And then you look on ultrasound to see if there's liver or metastases anywhere else. And as I said, these tumours usually, they respond reasonably well to chemotherapy, surgery, and somewhere between 3 to 6 months of chemotherapy. And for most of these children, we would give chemotherapy to begin with. That shrinks the volume of the tumour, and it makes the surgery more effective. Usually the surgeon can cut them out quite easily, and it reduces the, if you do primary surgery, there's a risk that you'll spill some of the contents of the tumour into the peritoneal cavity. And the chemotherapy is usually fairly standard. It's doxorubicin, actinomycin, and vincristine, just 3 drugs, 2 or 3 drugs for somewhere between 15 up to 6 months. But these children are usually good. And as I say, 5-year survival is about 90% if you get the tumour in the early stages without lung or bone metastases. If they've got just metastases into the abdomen, that's not too bad. But if they've got metastases to the lung or bone, it's quite hard to treat. There are certain types of Wilms tumour that have a less favourable prognosis because they're what's called anaplastic. They're more aggressive types of Wilms tumour, but they're a bit less favourable prognosis, but we still try to treat them. I mentioned neuroblastoma before, and neuroblastoma, they arise from the adrenal glands, and this is a child with a neuroblastoma. And I'll just go through the features on the CT scan. This is a normal liver, a normal right-sided kidney, and the left kidney is somewhere under there. This is the spinal cord and the vertebral body, and the spleen, and this is just normal bowel or stomach gas, and this is the big neuroblastoma. And you can see that it's a bit cystic, a bit solid. It's got some heterogeneity to it, but it looks like it's a bit encapsulated as well. So this is a neuroblastoma. Again, these are tumours of the sympathetic nervous system. They arise from the primitive neural crest cells of the sympathetic nervous system. About 40% of them are in the adrenal glands, and some of them are in the sympathetic ganglia, in the posterior abdominal cavity or the posterior mediastinum, in the thoracic cavity or in the pelvis. They usually present, again, a bit like a Wilms tumor with an abdominal mass. They can, if they're advanced, most children with neuroblastoma, they present a bit later than a Wilms tumor, and often they present, unfortunately, with disseminated cancer with bone marrow involvement, or sometimes even central nervous system involvement, and often failure to thrive. They've been losing weight, and other features of metastatic disease. These two tumours are quite hard to treat, and And usually children with a neuroblastoma, they're much more unwell than with a nephroblastoma. There are some children with a neuroblastoma that actually have a good outcome, and even some that they don't need chemotherapy, but they're very young children. So they're for some reason, some children in the first few months of life can get a neuroblastoma, and they can even resolve without chemotherapy. And sometimes with chemotherapy, they can have a good outcome. The treatment is complicated: cyclophosphamide, carboplatin, cisplatin, etoposide, and doxorubicin. These are much harder to treat tumours than Wilms tumour. So we've talked about, just to recap, we've talked about acute leukemia, so acute lymphoblastic leukemia, both B and T cell. We've talked about lymphomas. We've talked about retinoblastomas, and we've talked about chest wall tumours and abdominal tumours. Now, I think it's probably good when we think about, if you want to study common cancers in children, then what you should do is have a think about all the different causes. A good way to start is have a think about all the different causes of the common presenting features of these cancers. So have a think about all the reasons why children present with pallor, or they present with easy bruising, or they present with bone pain, or refusal to walk, or frequent infections, or a lump anywhere in the chest or in the abdomen, and or they present with proptosis, or a squint, or just nystagmus. And have a think about all the different reasons, both cancer reasons and non-cancer reasons. And then when we see a child who's got pallor, we can think broadly about the different causes of pallor. If we see a lump, we can think broadly about the different causes of a lump, and cancer will be one part of the differential diagnosis, but there'll be other ones as well. So I won't go through that today. We've sort of run out of time, but perhaps at some stage we should think about all the different causes of this. It's even good to make some notes yourself and write down the different causes, both cancer and infections and other things that will cause these. Okay. All right. Well, that's all I want to say today. So I'm going to stop sharing my screen, and we've had a big audience today. So I'm happy to answer any questions if you've got any today. So I'll stop talking now, and if anyone's got any questions, please ask.
Good afternoon, everyone. Thanks, Prof. Thank you for the overview of the cancer and the notes. Just some comments. There was some talk about how retinoblastoma is common in PNG, and they were thinking there might be some link to the high carriage rate of HPV in mothers, but we haven't had done any studies on that as yet. Just the other comment is because we have difficulties diagnosing cancer a lot in every way, including Port Moresby. Sometimes it's helpful to know that certain cancers are common in certain age groups. For example, Wilms tumors, hepatoblastomas, retinoblastoma are uncommon in children more than 5 years of age. So if you have children less than 5 presenting with a growth around the eye or abdominal masses, those are the first things you think about. And then you have sarcomas, which are common in children more than 10. It's not to say that they don't happen in the other age groups, but it just helps with diagnosis sometimes. Thanks.
Oh, thanks, Gwenda. That's really helpful. I mean, for those who are just starting their diploma of child health, I should say that Dr. Anger is our oncologist, oncology pediatrician, and Dr. Anger has been looking after the children with cancer in, or most of you know, I'm sure, but for those who don't, Dr. Anger has been trained in oncology in Australia after she finished her master's degree, and has been working in oncology for a long time. And so if you have questions about children you think might have cancer, then please refer them to Dr. Gwenda Anger. Thanks, Gwenda, for that input. And I'm sure you'll do some teaching on other oncology issues later on. But thanks, Gwenda. That's helpful. Okay, well, if there's no further questions, we might stop there. It's been a long session today, and I hope it's just an overview of just a brief introduction, I think, to different types of cancer, but in children, and it's good to study them yourselves. I'll send the notes around in the coming days, and you can just go through them perhaps, and if you've got further questions, then ask Dr. Anger or myself. But thanks everyone for attending today, and we'll see you next Monday.
Thank you, Prof.
Thank you, Prof. Thank you.
Okay. Have a good afternoon, everyone. Bye-bye.